My name is Melanie Everitt, and I'm the Medical Director of Heart Transplant at Children's Hospital, Colorado. I'm a professor at the University of Colorado in Pediatric Cardiology. Heart transplant is a very specialized field in pediatric cardiology, and it takes a dedicated team of multiple specialists to care for children with advanced heart failure and heart transplantation. Between 400 to 500 heart transplants are performed each year in children throughout the world. The most common reason why a child needs a heart transplant varies by age. In infants, congenital heart disease is the predominant reason. In the early 1990s, heart transplant was often offered to infants who had complex congenital heart conditions, such as hypoplastic left heart syndrome. It was soon realized that there would be too many infants dying while waiting for a heart transplant due to a shortage of donor organs. During the same time frame, outcomes in congenital heart surgery improved, such that surgical palliation is the first treatment now for most complex congenital heart lesions. Heart transplant is only indicated when cardiac surgery is likely to fail. Some examples of cardiac conditions where heart transplant is considered the best option are in infants with severe coronary abnormalities, those with myocardial dysfunction that will likely worsen if heart surgery is performed, and infants with hypoplastic left heart syndrome who have abnormal and a poorly functioning tricuspid valve, or an abnormal pulmonary valve that cannot be used as the new aortic valve. While these decisions are made postnatally based on the echocardiogram of the newborn, it can be very helpful to the parents to understand prenatally that heart transplant is a possibility for their baby. In older children, the most common reason for heart transplant is cardiomyopathy, with dilated cardiomyopathy representing over 80% of heart transplants for children with cardiomyopathy. Whether heart transplant is a consideration for the treatment of congenital heart disease or cardiomyopathy, the goal is the same. The goal is to preserve the health of the child for as long as possible with the heart they were born with. The reasons for this are multiple. First, some children have recovery of their cardiac function after being started on heart failure medications. Second, heart transplant carries a low but real risk of perioperative death due to primary graft failure, which is lack of a functioning graft within the first 24 hours after heart transplant. Heart transplant recipients must take lifelong medications to suppress the immune system, which puts them at risk for secondary problems, including renal failure and malignancy. The average half-life of the graft is longer now than in the 1990s and early 2000s, but the half-life, which is the time when 50% of children are alive with the initial heart transplant and 50% of children have died or needed a retransplant, is approximately 16 years. With respect to cardiac recovery and survival without heart transplant in children with dilated cardiomyopathy, I've been privileged to work with the Pediatric Cardiomyopathy Registry investigators on a number of studies. The first study was in children with idiopathic dilated cardiomyopathy. These were children who had no known cause for their cardiomyopathy and had both a low fractional shortening or ejection fraction and a dilated left ventricle at the time of diagnosis. In this analysis, we found 22% of children with normalization of their LV size and function within 2 years of presentation. Interestingly, there were some children with extremely dilated ventricles and very poor contractility who had completely normal function and LV size at follow-up. A more recent study, published in 2017, shows that survival in children who did not receive a heart transplant as part of therapy for idiopathic dilated cardiomyopathy has improved in the recent era. This figure shows better survival from 2000 to 2009, shown in red, compared to an early era, 1990 to 1999, shown in blue. The challenge continues to be identifying which children will recover or survive without heart transplant, and how can we support those children through the episodes of acute heart failure when the risk of dying from the heart failure is greatest. As a heart transplant physician, I want to avoid or delay heart transplant whenever safely possible, but I want to be sure we list a child who truly needs a heart transplant before the child is too sick to survive the waiting time for a new heart or too sick to survive the postoperative course. The postoperative course is a particularly vulnerable period. This is because it takes time for the child's other organs and the new heart to completely recover from transplant. During this phase, they are receiving a sudden barrage of inotropic support and immune suppression. Our median time for a child receiving a heart transplant is relatively short in Colorado, but this time varies by the child's blood type and size. Therefore, early referral is critical. A referral for heart transplant does not necessarily mean that child will be listed for heart transplant. Some children have other medical or surgical options that we can identify and recommend to avoid or delay transplant. It is rare, but does occur when children are too sick for heart transplant, particularly if they have severe problems in other organ systems. Pulmonary hypertension is problematic because the child may not have any signs or symptoms that indicate pulmonary hypertension until it reaches a severe and irreversible stage. For children who are doing too well for heart transplant, the referring cardiologist continues to follow the patient, and we are available for specific questions. We can also see the patient at 6 to 12-month intervals, depending upon their cardiac condition. For children who have contraindications to heart transplant, we do everything we can to treat these comorbid conditions and improve the child's likelihood of surviving a heart transplant. Contraindications to heart transplant include the following: severe, irreversible end organ or systemic disease that would result in a low likelihood of surviving the transplant, the presence of severe and fixed elevation in pulmonary vascular resistance that would lead to early right heart failure of the new graft, hypoplasia of the proximal branch pulmonary arteries or pulmonary veins, because these vessels are not replaced with heart transplant, the presence of ongoing acute rejection in a heart transplant recipient who's being evaluated for retransplant, and active malignancy. Other contraindications that may be modifiable include an active infection, insulin-dependent diabetes mellitus with poor glycemic control, morbid obesity, active tobacco use, drug or alcohol abuse, medication noncompliance, and untreated psychiatric disorders. For these to be modifiable, early referral and identification of these comorbidities is imperative. Our general approach is to start with a heart failure consultation to determine the need for heart transplant and to provide a framework for the family and patient to understand the evaluation process. Following an initial consultation, the patient will either be fully evaluated for heart transplant with our multidisciplinary team outlined here. The patient will be followed closely by the referring cardiologist until the heart failure or condition progresses to the point of needing a heart transplant evaluation. Or the patient is found to have contraindications to heart transplant, and efforts are made to address these. Additional discussions with social work, psychology, and palliative care can be provided in these situations. An alternative treatment plan can be determined with the patient, family, multidisciplinary team, and referring cardiologist. If you have any questions about heart failure management or heart transplantation, please visit our website.